beach and not attending a seminar. So, so thank you so much. My name is Sahr Wali. I'm a scientific associate at the University Health Network and assistant professor at the University of Toronto. My background is really in health equity and innovation. I do a lot of work working with underserved communities across Canada, specifically our Indigenous populations, as well as in Uganda. So with that, I thought for the title of my talk, just confirming you guys can see my slides. Great. I thought we can really ground ourselves with this title called Beyond the Blueprint, Designing Digital Tools with Meaning, Not Assumptions. So for myself, I did my PhD at the University of Toronto in health informatics, and I found that as we were learning about different frameworks, different tools, there was this consistent trend that a lot of these interventions commonly served and benefited our more high income, high literacy communities, whereas those that were often in the ER or they were often needing those extra supports or not necessarily being included within the design process, nor were our systemic situations being considered throughout the entire development process. So with that, I wanted to introduce myself by saying this is really what I look like. I'm a second generation Canadian. I am a middle child of five. My parents were, very privileged to be able to immigrate from Afghanistan to Canada and raise five kids. And I found that with myself, I grew up in a predominantly white community, and I felt like there was always a sense of identity that I was chasing. And although I was super privileged to be able to be born and raised in Toronto, Ontario, on the lands part of Treaty 13, I always felt that there was this misgap where I was serving as the caretaker for my parents, despite them speaking fluent English, despite them being in the country for over 30 years. And as I went towards my PhD, I felt a sense of responsibility that I want to be able to support others who are facing these similar obstacles, not because they come from a deficit, but really because we don't see the strengths between different cultural worldviews. We don't see the strengths between where people are coming from and how all of this will feed into more meaningful interventions, more meaningful impact, and improvements in health and wellness overall. This is my lovely nephew. As you can see, I do not have children, but children clearly have a mixed view of me. So with that, I thought for our seminar, we can start by going over the gap in digital health where we might have good intentions, but they sometimes miss the mark with our underserved communities, and then going into context as a design requirement. A lot of times within user-centered design, we speak about concept, we speak about user needs, but not necessarily how the digital divide changes how context looks like for different community groups. Then leading into the topic of presence, pace, and perspective with two case studies from Uganda and Northern Ontario, which is where the bulk of my research is. And then looking at what does relational co-design actually look like in practice? How do you apply different methodologies, different frameworks from different cultural backgrounds within user-centered design, within the informatics stream? And then speaking to a few of my lessons learned on the reality check and the value of the pivot, when plans change and how to stay accountable to your community partners. And then ending off by talking about how do we redefine success measures beyond adoption, looking at things like trust, relevance, and lived experience. So with that, as many of you guys know, in our era of digital health, a lot of digital health interventions have been shown to improve things like efficiency, communication, costs, and quality of health services, but there's still this mixed evidence supporting improvements in health outcomes. And we really saw this during the COVID era when there was this big boom of both health interventions as well as virtual care supports. But the reality really is that digital health tools are designed to help users with a specific task, but they fail to recognize the context of the user within task completion. So really take a moment to sit with that. Their digital tools are really designed to help users with a specific task. Is that medication management? Is that titration? What does that look like? But they don't necessarily consider where it's being completed, how the task is being implemented, and all of those contextual barriers that lead into that task actually being conducted. So that goes towards this idea of the digital divide, where health promotion is not this one size fits all approach. There are various cultural, social, structural factors that shape whether digital tools reach or exclude the people who need them the most. Things like age, sex, access to education, work, unemployment, housing, all of these factors that really incentivize or allow an individual to be able to utilize the resources around them. And this is where we get into the gap between design and impact. In the promise of digital health, we talk about things like improved efficiency, communication, reduced healthcare costs, enhanced quality of services, remote monitoring, and then you start to question yourself and ask, am I really being a snake charmer and am I promising this idea of digital health, or is it the reality that we don't necessarily know if it's going to make people's lives easier? Do the tools actually ignore a user's context? Are we using predominantly Western design defaults to dominate what a tool looks like and how it's introduced? And is equity really an afterthought or included within the initial design? And is that resulting in widening these digital divides that are occurring between our more underserved communities? And when I say digital divide, this can mean so many different things. It can talk about access to technologies. It can talk about broadband and Wi-Fi in Northern Ontario, Canada, where a lot of our Indigenous communities reside. We find that access to broadband is something that has been a big issue, but there are gaps in resources that can mitigate those, such as things like Starlink or other sources. And then on the other end, when we look at the innovation of things like wearables, are we considering how wearables may be inaccurate for those who have higher melanin contents? And are we using that to actually show impact, or are we widening the risk for our communities that are of high melanin concentration? So this is where we get into the implications of conventional design research. And I say conventional design research and user-centered design so my bosses don't get me in trouble, because user-centered design is great, but I think where it struggles is it really asks people to meet them where they're at with us taking the accountability to understand what that means for the user. So we emphasize, define, ideate, prototype, and test, but what does that really mean? Whenever we have any user-centered design study or any product development, right off the bat, the first thing that we're doing is we usually have speaking English as a requirement for study participation. And I can guarantee you it's those individuals who do not speak English or do not feel comfortable or want their caregiver present that are the ones that you would want to be included in those conversations. But right off the bat, we're pigeonholing ourselves in the area of inclusion. And on top of that, there is this idea of this power imbalance where the researcher designs, the community participates, and knowledge really flows one way. How can you ask someone about their story and their opinion and how an intervention can be designed when you're coming with these pre-designated ideas that are grounded in your worldviews and not necessarily the users? And then on top of this, a lot of the times when we have a study, and I know I'm guilty of this myself, we write our paper, we have this wonderful intervention, and then when we talk about our limitations, we list all of our equity gaps as a limitation. And that's not necessarily a limitation, but I see that as a failure of our methods because we're not beating people. We're not changing our recruitment strategy. We're not changing how we onboard. We're not advocating to have community ambassadors to be the ones to support equity not as an afterthought, but rather or myself, we take the easier way out and align it as a limitation instead of doing the work and asking, why is it that continues to be a challenge? In addition to this, when we have our focus groups, our interviews, any iterative design cycle, we have this Western ideologies that really privilege hypotheses. And then, as you know, with a lot of underserved communities, the way they share their story, it speaks in this more relationship or relational experiences as this is their livelihood, but we don't provide them the opportunity to share their feedback in that way. And that really results in all this context from being stripped away and individual behavior really being overshadowed by community level determinants. And as a result, I find that, success is really misdefined. We talk about adoption rates, efficiency, how many users are using a program, but we aren't necessarily asking, are they benefiting? And how is the idea of someone benefiting being defined? Is it I'm defining how a community benefits, or is it they are articulating what success looks like to them? But how can you allow someone to, provide those definitions when they don't even have a seat at the table? So with this, you might be asking, what is this crazy girl talking about? I wanted to introduce this idea of presence, pace, and perspective. The first being when you are present in a community space, and this can be a community group, it can be a hospital setting. A lot of the times, the feedback that you get from surveys and focus groups, it cannot equalize the idea of just being present and, allowing yourself to work with an individual, work with the community without any other ultimate goal. Just being present and asking others what they would need and how you can support. That really changes how context looks like. It provides a level of authenticity because you can't really meet people where they're at if you're not even there. And the second piece is on pace. I know we are all stripped by our grant deadlines and our academic calendars, but we really need to slow down on these community-led timelines to replace these researcher-driven schedules because genuine participation cannot be rushed. It might not be right now, but that's not rejection. It's a signal about trust and readiness. And I always tell my students and others that if you have a first date and then the next time you tell someone that you want to get married, that's probably a red flag. And why is it that in research we have one initial consultation and then the next time we expect a full-blown collaboration? We expect all of these design principles and all of this meaningful feedback to be provided and people to share their stories and their livelihood when they've only ordered their appetizer. So why is it that we have this sense of onus on the individuals that the system has really failed the entirety of their lives? And then in addition to this goes to the last piece on perspective. A lot of Western ideologies and epistemologies, they talk about this deficit-based mindset. What is the rate of heart failure in Black and other ethnic minorities, not necessarily considering, how communities been resilient. And this is where I really challenge academics. It doesn't mean you have to throw out all of your training, but it means you have to be open to the idea of looking at different worldviews and viewing knowledge from different lenses. And this goes to one of my favorite ideologies of your truth is not my truth. It's an Indigenous ideology, and it speaks to the idea that a lot of these social determinants of health trickle down to the impact of things like cardiovascular disease, depression, but it considers the fact that colonial mindsets have trickled down into healthcare systems, health behaviors, and that has resulted in the systemic condition and the physical condition that a lot of communities face that reduces the onus on the community on being responsible for those conditions. So now you might ask yourself, where do we start? I've mentioned all of these things, talking about how user-centered design potentially sucks or potentially could be modified. And this is where I like to talk about the idea of research and rediscovery. And it really tries to challenge the idea of removing study participation to a research partner, going from the traditional Western mindset of community members having no influence on the design to really having this idea of community members having the entirety of the partnership and the collaboration. And really asking yourself, whose research is it? My mentor, Dr. Ashley Mashford Pringle, she, during my PhD and during my academic trajectory, she always asked me, why are you doing this work? Who's defining the goals? Are the community's priorities driving the agenda, or is this the funders' requirements? Do the right people have a seat at the table? Is this meaningful engagement, or are you just checking a box? What does success look like? And according to whose definition, is it an academic output or a community, or are you actually trying to improve community well-being? And why are you doing this work? Are you losing sight of the purpose once you get started? And I find that a lot of people are guilty of this. You might come with good intentions, but as soon as you start the work, you forget all of the things that really drove you to the reason you started. And then the last piece on who benefits. Community benefits should be primary, not residual. It shouldn't be pushing publications. It shouldn't be pushing adoption and user engagement. It should really be defined by what the community views as of their benefit. So this brings me to an Indigenous framework called two-eyed seeing, and it really tries to look at the world in two lenses. So two-eyed seeing allows us to have one eye grounded in our Western worldviews and the other eye grounded in Indigenous worldviews. It doesn't mean that either is bad or good. It just means that we have to be open to our ideology of looking at things from where they come from. So in Western worldviews, we have this more deficit-based mindset, but we also have the value of looking at hypotheses, looking at prediction, study participation, and potentially the output of publication. But in a lot of Indigenous worldviews, and everybody is Indigenous somewhere, so when we say Indigenous, this can be to any ethnic community. We look at things from the idea of strengths, relationships, interconnectedness, having our communities be part of a research partner, and that output really being on community capacity. And these can be interchangeable between a lot of different variables, but the idea is when you're stuck in your own worldview of knowledge, you really pigeonhole yourself and give yourself tunnel vision on what meaningful outputs can look like. But by pausing and asking yourselves, whose research is it? Where is this context coming from? Am I interpreting this correctly? You are really keeping yourself accountable to do your double check and ensure that your participants are actually being the ones who are leading this work. So now I wanted to give you a case study to talk about how we actually implemented these type of ideologies into practice. So in Toronto, Canada, we have a program called Medley, which maybe some of you guys are familiar. And Medley is a digital therapeutic program that essentially uses a smartphone, blood pressure cuff, and a weight scale to provide remote access to heart failure care. And Medley right now in Toronto is standard of heart failure care, and I think it looks pretty great. We've been showing some great improvements across the region. But as we start to think about, the population of patients Medley is benefiting, no surprise, they're primarily high income, primarily coming from white demographics, despite Toronto being one of the most diverse cities in the entire world. So this is where we really want to challenge ourselves and ask, how can we take the essence of Medley and adapt it or modify it or look at it to make it more equitable and more meaningful for communities that don't necessarily look like the large demographic that it currently serves. So this is where we actually wanted to have our introduction into Uganda. And Uganda right now, they only have one specialized heart center in the city of Kampala. And we thought, what if we took Medley and deployed it? And originally, when we brought the program, and we thought that it'd be really great just to take the program, how it looks like in Toronto, and apply it in Uganda, no surprise, we learned that that's not going to work. And that's not user-centered design. So what we had done is we wanted to go over and build a partnership with the Uganda Heart Institute and from the ground up, really take the skeleton of Medley and see how we can work with our Ugandan partners for them to allow us to understand what does heart health and wellness look like in the Ugandan context, and how can we redesign a program that has been clinically validated but might not make sense for their context. So we're 4 phases. We had a lot of fun mapping out our project priorities, conducting a needs assessment, and then actually prototyping and evaluating it within the Ugandan context. So to do this, what we had done is we used the iReach tool, which is the Intervention and Research Readiness Assessment of Community Healthcare tool. And what it did is it really allowed us to break down each of our stakeholder meetings to have no pre-assumed agenda. So in our first cycle, we actually, put all our cards on the table, asked our community partners, both clinic and community, what they would want out of a program like this. And we found out that, aside from heart failure, rheumatic heart disease was a very big um, priority within the Uganda community. And they've really wanted to emphasize this collaboration with specialists because we had so much information and so much content. We actually conducted 2 validation cycles. And we had an in-person site visit where we then introduced this idea of village health teams, which is something completely new and novel to myself. And village health teams are volunteers in the community that actually go and do health checkups. So as part of this model of care for Medley Uganda, in Toronto, you only have a nurse coordinator. We wanted to really leverage the role of these VHTs. So over the next couple of cycles, we actually added the role and improvised our study approach and co-developed all of our materials to go ahead and include both our community and clinic partners. So as a result of going over 4 cycles, we confirmed the area of focus to heart failure and rheumatic heart disease. We identified our clinic champions to strengthen the project team. We updated our clinic, our community engagement strategies to have local translations, and we integrated our VHT as core members of the project team. Moving forward, as we went into our interviews, we actually also used a lot of Indigenous methodologies that were based in Canada within the Ugandan context. And specifically for our interviews, we use these more yarning style interviews, which are more storytelling like. And the Ugandan team really appreciated that approach because they found that their patients felt very comfortable in sharing the details of the stories that they have experienced. As in Uganda, across all 5 of our themes, we found that there was this big stigma on anything chronic disease related. If you had heart failure or a heart condition, you were viewed as a lost cause. So when you're asking community members to share their stories and give input on what a program should look like, right off the bat, it's very stigmatizing. So looking at the way you're asking the questions, who is asking the questions, who is in the room to create that safe space, all of that has been considered before we have even started an interview, which really goes back to my initial point on who has a seat at the table and why are you doing it? And are you really being equitable in your approach? and hopefully we did well against our partners. So as a result of after 60 interviews, we came across five themes. The first being this disconnected journey of heart health management. No surprise, we found that there was this very abrupt diagnosis, a lot of the travel burden, limited care frequency. People were traveling over 3 hours by motorbike to actually be seen at a nursing station, and a lot of financial constraints regarding medication availability obstructed people from even wanting to have any care support. In our second theme, we talked about overburdened clinics, the limited specialist availability, and how a lot of those VHTs, that although they're volunteer-based, they were really undervalued and undertrained. And those were the ones of people actually felt the most comfortable sharing their insights with instead of their physician, as they did not want to disappoint the doctor that they spent 5 to 6 hours to go see. And our third thing, we talk about community strength is built on trust, having a community focus on housing and income. A lot of patients also turn to healers for cost reasons, which was a piece in our model of care that we wanted to consider, but not necessarily fully promote due to the mixed stigma. And then when we talk about sustainability of an intervention, collaborative efforts really was the key piece to promote self-care. We needed to have education and training resources that met community members where they are, and that they were open to digital tools, but nobody had a smartphone. Everybody had a simple feature phone like a Nokia. So if we want to reduce travel burdens, we want to have remote symptom monitoring, we need to strip the entirety of the Medley program and really take the skeleton of the algorithm and figure a way to deploy it in a way that would be accessible to community members across the country. So what do we do with this information? Great question, Sahara. Thank you for asking. So what we had done is we actually did 10 co-design sessions with our Uganda partners in two of the most remote regions. And we ended up creating something like this. So we found out first, the priority of heart health is minimized. So what should we do? We ended up creating a lot of educational materials with a Ugandan artist. And a lot of this talked about, what is heart failure? What does the healthy diet look like for you? What are the causes of heart failure? And this introduction to the program, as well as an educational aid, it gave community members a sense of control. It allowed them to feel that they were getting information in a way that was meaningful to them. And all of this has been translated in over 6 languages. We found that a lot of community members felt that they were able to even share and explain their condition to their family members who would otherwise have thought it was a helpless condition. Next, when we're talking about the lack of care continuity or relationship building and clinic workflows, we wanted to change the model of Medley to still, have the nurse support, still have the clinician dashboard. But as you can see, we basically took the algorithm of Medley, put it on to a simple Nokia device, launched on a free Ministry of Health platform. And on top of that, we took away any blood pressure monitoring or weight monitoring, as these devices are not necessarily available, and allowed the nurse alerts to have a bit more of a safety guard to prompt them during a follow-up call. And in addition to this, because we know there's lack of specialist care available and the VHTs are undervalued, what we wanted to do is we actually created these clinic supports for our nurse coordinators to talk about how to actually conduct the calls, talking about what alerts would look like. And then finally, within our financial constraints, we made sure that the program was free to use for the entirety of our pilot, as well as now as we're launching in 6 hospitals. So as a result of our pilot, we actually conducted this in Kampala, and we had about 66 participants. And as you can see, this version of Medley looks very different than what it looks like in Toronto. But the questions, the way they're asked, as well as the alerts and the responses that you get are the same. And as a result, we actually found we had an 86% decrease of patients being reclassified as NYHA class 1. We had a significant decrease in hospitalization and a significant increase in medication adherence. And this was all with the initial, archaic system of Medley Uganda, further showing that, innovation doesn't have to be complicated, but all of these contextual adaptations is the reason that we had these positive findings, from the educational supports, from the model of care, to how the nurse was trained, as well as how it was accessible to, a simple feature phone. If we did not make those adaptations, we probably would not have, we would probably not have more than 20% of patients actually complete the study. So I want that's Medley Uganda in a nutshell, and I wanted to shift gears a little bit because we're talking about a lot of these digital innovations and the revisions that we have been making. But I also wanted to talk about, sometimes innovation, and when we talk about the blueprint of impact and meaningful digital interventions, it doesn't always have to be digital to be innovative. And when we're talking about impact, we really have to question who is defining how innovation should be seen. And one of my favorite studies is a study in the US looking at, Black barbershops and how they had a pharmacist, sit in these barbershops within predominantly Black communities, and they did blood pressure screening. And as a result, they had tremendous impact. They were able to meet people where they're at and, not necessarily obstruct their lifestyle. So in my logic, I was thinking, why is it that we don't have this similar model of care within the digital health space? We're always asking people to travel to a hospital center, pay 20 bucks for parking, get there if you're elderly or frail, the process of going into the city, all of these obstacles, to conduct a study that's promoting wellness or promoting access to care. But I really think it's the easy way out for the researcher to not necessarily look at these community-based models. So this is where we start to challenge ourselves and ask, where can this type of design thinking also be applied? And this is where we get into our lovely pamphlets that I tell everybody, when I was a kid, the only benefit I had from looking at these pamphlets was I'd pull it out and told you I'm a middle child. I would point at something and say to my sibling and be like, hey, that's you. And that's the only benefit I've ever had from these pamphlets. So now like shifting gears, looking at how can we community meet people where they're at with our partnership in Northern Ontario, a lot of Indigenous communities, they value this idea of storytelling. So we thought, how can we take this essence of storytelling and apply it within our delivery of Medley, as well as our share back of our community-based study? So we actually conducted a couple of sharing circles, which are very similar to focus groups, but it provides that level of authenticity and openness with an elder in Indigenous communities. And after completing this study, we basically took all of our qualitative findings and we used graphic medicine to turn it into a comic. So as you can see here, this is, our heart and in Moose Factory in Northern Ontario. The hospital is actually on an island. And because because of challenges with access to actually get to the hospital, so you can only get there through a helicopter during the breakup season or through the ice road or through a boat taxi. And we wanted to provide this visual to not talk about the deficits on access, but talk about the strengths and resilience and the creativity of the community from still being able to get their loved ones the care support despite the obstacles that they're facing. So to further go into our case study in Northern Ontario, right now I'm in Toronto, which is about south here. But if you're in these communities, you're traveling 3 to 6 hours by a charter plane or multiple stops to be seen at not a tertiary care center, but primarily through with the family doc. And these are the obstacles that a lot of patients face. So what we wanted to do is not necessarily drive into how these obstacles obstruct care, but really provide like a sense of authenticity to acknowledge them, but also talk about the resilience behind them. So by using this more comic-based report of storytelling, community members, they really just felt that they saw themselves in these stories. They saw themselves in this experience of, having a different locum physician every month, coming in, flying in and out. And we're still introducing the idea of innovation, introducing the idea of medley. And I love this angry old man who does not want to be bothered. But it goes back to the idea that, when we're talking about innovation and we're talking about recruitment and onboarding and how do you get people to incentivize and understand why a program like this would benefit, I really challenge everyone to ask yourselves, are you providing materials in a way that would resonate with the user, or are you going through your traditional box of, providing, just traditional recruitments and going through your traditional onboarding processes? This graphic report was really used as a source of onboarding, but what we also had done is we took the idea of Indigenous storytelling and we further developed it into an animation. And it looks like this, where our elder, we turned him into a beaver, as Beaver was noted as a storyteller in Indigenous communities. And we actually took live images of the community and the process of how and what it looks like to get around community, accessing care, going across the river, what the hospital looked like. And we worked with our local Indigenous animators, and we ended up creating something like this. And this is something that was shown. As you can see, we still have our Medley shout out. And when we're talking about recruitment, onboarding, and giving a sense of reciprocity to the stories that were shared, a lot of community members were thrilled. They said, this looks like my cousin. And our elder said, hey, how come the beaver's not giving the boat driver $20? That's what the cost is to get across the river. And all of these pieces really speak to the fact that yes, we're in user-centered design. Yes, we are using Medley. Medley is a great program, but to get people to understand the why and to build that relationship, that sense of trust, these are the types of approaches that people we find value. And it will look very different in different communities and different partners. But I think by providing yourself to take a step back and allow our community partners and our research participants to lead conversations, that's where meaningful change happens. It's not by the comfortable and the familiar. I think meaningful change comes from uncomfortable conversations, and that's where I think we really need to thrive in the academic sense. I also want to give a shout out that we submitted this animation to the Toronto Short Film Festival, and we actually won an award by two of our Indigenous animators. And this was a fantastic showcase of community collaboration. And I feel like this was my baby, so I just wanted to give a shout out to that. Now, going forward on the topic of how innovation doesn't have to be digital, you might ask yourself, how do we continue to meet people where they're at? And as part of our work within Indigenous health, food security is a big challenge. And when we are doing our community-based work, we're providing clinical care, we have deployed Medley, and we still found that, patients aren't doing so well. And this is where the idea of Rivers of Plenty came, where we actually are conducting a community-based research project to figure out how can we create community supports in community to provide, access to traditional food, greater access to food autonomy or food sovereignty and so forth. So what we had done over the past 2 years is we have hosted gardening workshops in parallel to our deployment of Medley, in parallel to the clinical supports. And as part of that, we've also created a series of resources that are grounded on how do you grow and create a garden within the northern climate, because the soil and the growing seasons looks completely different. And when you have your growing seasons, what does it look like to eat the parts of the moose or the parts of a goose in a traditional sense? What are the nutrients? This is the idea of taking this knowledge and these knowledge systems and not necessarily saying that, oh, no, you need to work with a dietitian or you need to do this, but it's bringing the information in a familiar format, acknowledging the strengths of different cultural backgrounds, and then bringing it back to, what is a heart healthy diet? How can you work with your Medley coordinator or with your nurse practitioner to go and have these conversations in a way where you are able to articulate the information that best resonates with you. And I love these graphics and this information because I did not know the value of moose and goose meat, and it was great to see the benefits in a different lens. So as I end off, I just thought I'd talk about, a couple relational pieces for co-design. I think, the tenet of nothing about us without us still stands across the board. And if I can say anything, it's that, community partnership is always first. It really relationships precede research, and we really need to build trust before building tools because our communities are our partners, not our subjects. This idea of two-eyed seeing, it really honors Western scientific and Indigenous knowledge systems equal, and neither is subordinate. We just really need to ask ourselves and question and challenge who has a seat at the table. And then not necessarily just looking for data, but having iterative presence, not having our one checkbox says, yes, we consulted, but having that continuous discussion and really asking ourselves, is reciprocity being met? Are findings returned in accessible format? And are we using a strength-based lens that amplifies existing community assets? And really thinking about when we're talking about success, shifting our metrics from adoption efficiency to instead looking at things like trust, relevance, alignment with lived experience. So when we think about, what does redefining success look like? We're moving away from adoption, looking at trust, looking at cultural relevance, lived experience, participatory validation, and community capacity as an endpoint. Because a digital health program can be great as a pilot, but if when you leave it stops, is that really a success? Is that really impact? Or is it the continuity and the growth what we should strive for? So my key takeaways as I end is, context is not a variable to control. It's really the foundation of meaningful design. And, modifying our methods from the point of ideation, it really enables this more genuine intervention design. And I think using methods like two-eyed seeing really restores context and gives individuals the power to define their own well-being. And working in partnership to amplify these strengths, it really leads to more relevant and trusted tools. And last but not least, as a health informatics researcher, innovation is not always digital, and presence, pace, and perspective really matter more than platforms. Just don't tell my boss. So thank you. And if there's any questions, happy to answer.